Liz is a dedicated patient partner at the New South Wales Agency for Clinical Innovation, where she plays a pivotal role in enhancing capabilities within organisations and its partners to effectively collaborate with consumers in the design and delivery of health services. With a rich background spanning 18 years at the Hunter New England Local Health District in various educational and consumer partnership roles, Liz has been at the forefront of person-centred initiatives. Notably, she pioneered the state's first consumer participation unit and has been a strong advocate for systemic changes to foster human-centred healthcare. Her collaborative efforts have led to significant innovations such as the police and ambulance early access to mental health, triage via telehealth, and the Hearts in Health movement, and the Towards Zero Suicide initiative. Liz's commitments to this field is deeply personal. Her lived experiences with mental health, suicidality, and surviving domestic and family violence have profoundly shaped her approach. These experiences not only fueled her passion, but also equipped her with unique insights that bridge the gap between clinical operations and individual patient experience. Liz leverages her storytelling skills to advocate for meaningful, empathetic engagements within healthcare. Liz today will share invaluable insights on what staff need to be open and willing to engage in two-way feedback. Welcome, Liz.
Thanks, Tina. That's excruciating hearing all of that and should never be done. There we go. So welcome, everyone. I want to acknowledge I'm dialing in from Awabakal country in Newcastle, New South Wales, and it's a real joy to be here. A little nervous, but I'm sure from what I've seen so far, you're a very forgiving and welcoming and warm group of people. I want to talk about this from the perspective of the things that I have seen, heard and listened to over the 14 years I've been in lived expertise roles, and they've all been roles embedded in the public health system in New South Wales. So as a consumer consultant, as consumer participation lead and engagement manager for Hunter New England Mental Health Service, and now as patient partner at the ACI. And these lived experience roles are roles that require me to straddle two worlds, the world of health staff and the health system, and the world of consumers, families, and loved ones accessing the system. What you see in front of you there are a couple of quotes that I've heard said to me many, many times. And I think it's really interesting because what I take from that is that I feel as though my peers, my clinical peers, my support peers in health believe that a lived experience role perhaps gives the person in it a license to connect with patients and families in a way that sometimes staff feel they can't. That by virtue of having lived experience on my name badge, it gives me permission to connect. And we've heard from other speakers these ideas or these themes emerging around power, and these themes emerging around culture, these themes emerging around, someone's even said staff may even be afraid around feedback. And I think this information in these quotes is really valuable information worth unpacking alone. So my quick tour of my mind when I brainstormed what staff might need in order to engage in two-way feedback. Here it is, a busy slide. I believe that people need to feel they have permission. I believe that we need in health to shift from a transactional paradigm to a relational one. I believe we need time, and I believe we need to feel safe and capable to do so. I also believe that despite considerable rhetoric around the value and the drive for patient experience being a priority within public health systems, the odds are actually stacked against human connection, shared power, and person-centeredness. We do have policies, papers, guidelines, standards, all that say that we should be partnering with consumers, but they don't tend to be yielding any real impact on the ground from where I stand. And I don't believe that you can have human-centered service in a context that favors speed, volume, and transactional engagement over actual relational connection. You can't have two-way connected conversations if the time is not afforded to that and the processes aren't made safe and respectful for all people participating. We've got to recognise that our system and our policies and our processes and our structures don't foster connection and equity and shared power. And in some instances, they actually deny it. And I can give you a really concrete example here of the number of times as a peer worker working in a mental health unit at the Mater Hospital in Newcastle, staff would often use privacy policy as a reason for not inviting families and loved ones and carers into case consultations and case conferences, and also care planning. Ironically, they were perfectly happy to discharge people out into the care of these people with no support or inclusion in what they were expected to do for that individual when discharged back into their care, but they weren't allowed to be involved in the process because of things like privacy agreement. We have policies that inhibit connection. Our funding doesn't promote connection. Funding is all around activity. For all the activity you do, the volume, you get dollars that equal that. That's my very elementary understanding of ABF. There isn't any funding there for what was the quality of time that you spent with individuals. There's no value placed on that kind of activity. We've got to remember as well that our feedback mechanisms that we traditionally use promote and perpetuate power differentials. I once provided some feedback to a local hospital having had to use the ED, and the feedback was submitted online. I then maybe got an automated response. I then got a phone call maybe about 2 weeks later from someone who had investigated the claim, hadn't spoken to me, but had investigated the claim, had investigated with the staff member involved, and had decided that yes, X and Y had happened, but here are the reasons why, and am I now satisfied? There was a really missed opportunity there for me to connect with that registrar and explain why I'd had the experience that I had and why my feedback was what it was. A real missed opportunity. So we need to also recognise that we do have mechanisms that can promote a culture of blame and retribution as well. We look at things like our root cause analysis process when there are critical events or deaths in care. And the whole purpose of that is to get to the bottom of it and find out who had a role to play, what had a role to play. And with that, it just smells like blame. It smells like fear. There's no wording around the process of what can we learn from this? What do we want to do better? How can we understand how this happened? Do the people that had a role to play in it need some support, as well as the people whose family was impacted might need some support? I'm really nervous about this, and this as well as a reflection of that idea of staff not wanting to engage in feedback. Even kind of pointing out some of these things that I'm doing here is making me feel a little bit nervous and sweaty, as though I'm going against the agreement. But I think it's really valuable to just say what I've observed and what I've heard. So what do all people also need? And I think here we need to talk about the fact that people need courage. We can't necessarily shift the entire system as individuals, but we can look at one part of it and make a commitment to shift that. And sometimes that first step might be you're going to make a commitment to yourself to do things a little bit differently. And that might mean in your own little space that you challenge the power hierarchy that resides within models of feedback. And you might say, even though process says this, I'm actually going to call, or I'm actually going to have a Teams video link, or I'm going to bring the person in face to face, and we're actually going to take some time to connect and get to know one another a bit before we even look at the problem at hand or the feedback that they're coming to us with. I invite people to, as has already been mentioned, remember your origin story. You came into health because you wanted to care for people. You wanted to make a difference, presumably. You wanted to go away feeling like, yeah, you turned someone's world around in that moment, in that hour, in that day. And one way of finding out whether you are actually doing that or how you can do that better is connecting, is having conversation, is relating, is understanding. And when you talk to people, it's a different type of feedback to what you get from your manager, or you get from the system, or you get from a survey. It's something that you can kind of unpack together and find out more and learn from. I really love that idea. And that, I guess, is that idea of shifting completely from transactional to relational. It's saying there is power in two-way conversation where we both bring courage, we both bring open dialogue, and we're real. We both recognize that people get hurt often in the context of a relationship, which in this case is often clinician patient, system patient, administrators patient. So conversely, people can heal in the context of that relationship. So in a sense, the mechanism and the process of feedback is in itself a mutual kind of healthcare. Maybe that's a big reach, but that resonates with me. I think when we get together and we listen to one another and we listen to one another's perspectives, we are able to build knowledge, understanding, and capability with consumers and our communities. They don't know what they don't know. And if we keep our systems as closely guarded as we do and why we do the things we do, we'll forever remain a mystery, and people will fill in the blanks with whatever story they come up with. So we actually have an opportunity to kind of build capability in the community and knowledge and understanding around what we do and why we do it. I think also under courage, people need to have the ability to self-reflect and have a strong stomach. I got sober through going to Alcoholics Anonymous, and step 10 of Alcoholics Anonymous is continue to take personal inventory, and when you're wrong, promptly admit it. Now, that is a significant enough action identified by this, amazing fellowship that will help a person stay sober and stay in recovery. So to me, it feels like, how can a system stay on track and in recovery? Then by doing the same thing, continue to take inventory, seek feedback, seek ideas and thinking. And when we're wrong, promptly admit it. There is such power in accountability, but I don't see that a lot. I see fear of accountability. I see shame attached to accountability. And I think they are lies we're telling ourselves. Accountability builds trust. It builds confidence in us. And accountability promotes collective healing. I totally think that. So I think I'm going to wind up now, but I think what we also need to recognize is if we have courage and meet people as they come to us with that level of courage when they want to give feedback, we have opportunities abound. We have opportunities to learn. We have opportunities to design solutions to problems together. we have opportunities to be really collaborative and get to the bottom of issues that we've often cycled through for decades and thrown different solutions at that have never stuck. Bringing feedback into that can help, bust through that change fatigue that staff often feel. And finally, I think I'd like to close with this, that individuals, as we go forward, trying to be the change we want to see in the world, and we want to be courageous and we attempt that, we got to recognise that we don't need to shoulder the responsibility of all the things wrong with the system. Then it's not our responsibility to shoulder. And just by listening to feedback and inviting feedback, it's not an admission that we are somehow responsible for everything that's going wrong. We're not saying that. We need to have some safety in ourselves with that and give the responsibility back to the people who it actually belongs to. And that endeth the sermon from me. Thank you, everyone, for having me.
Liz, you bring goosebumps. I don't know if you've seen that throughout your presentation, but if you haven't, I encourage you to go through the comments and the reactions. You've clearly really touched a lot of people in this time and through what you were sharing, and just to say thank you for your courage in what you did just share with us. That's not easy, and I think you've touched on issues that really resonate with a lot of our audience, and it's great to see for all of you joining us, you to be so supportive and create this safe space for these ideas to be shared. So thank you so much, Liz. Now, Keith, I could see your hand up, and so I just want to make sure you're able to ask your question or make your comments. Please do go ahead.
Thank you. I heartily concur with Liz and her statements. As a representative, as a consumer, I heartily agree with what she said with the hurdles that are there. Really are hurdles, and they shouldn't be. A lot of it is from systemic things like doctors and staff and things like that. I also like courage. To me, that was a terrific thing, to be able to have your say, and if you've made a mistake, put your hand up and take ownership of it. And in these days, it's something that doesn't happen anymore. Everyone likes to pass it on to somebody else. Sometimes it's a forward pass, unfortunately, but you get that on a big job. And importantly, or most importantly, I think, is communication. Without communication, mate, it works between clinician and patient, between staff and management, and all the way down. And I also believe that the idea of we have a patient-centered care, which is the people are supposed. Sorry, the clinicians are supposed to listen to what the carers have to say about what's going on with their patient, because they know what it is. If they come in, if a child comes in with a high temperature, and it gets hoo-ha'd out of the place because the child did have a high temperature and they just laughed it off, and take some Bex and have a lie down. But it needs to go further than that. There's one just recently where that sort of thing happened, and someone had scarlet fever. So that's a big thing. You need to listen to what the carers are telling you. Thank you very much for wasting all your time, mate. Thank you.
Thanks, Keith, and thank you again, Liz, for honestly and courageously sharing with us your message, which has resonated with many, and there's many that support your message as well. And having the right leadership, culture, governance that allows staff to be proactively engaged can also be some enablers, and we'll be discussing some of that in the later session. So enablers that allow staff to have the courage and that fearless accountability that you referred to as well, allowing people the permission and the courage. Thank you again, and any other questions, please do share questions, comments in the chat, and all of the recordings will be available after as well. And a lot of what has been shared we will use in the last session as we reflect and consult.